Now, why hypertension is important? It's, believe you me, one of the very important, perhaps the most important subject. Why? Because this is the largest contributor to human mortality. When you take the 10 leading causes of death, hypertension is on top. It contributes to a lot of problems. So you should be very much aware of this disease. And the unfortunate problem of hypertension is that since the primary hypertension is asymptomatic, a large number of patients do not know that they are hypertensive. And the second problem, those who are hypertensive, very few of them are at target when they are treated. So that are two main problems. And in our country, the figure is very, very dismal. You see, in developed countries, we find that almost 30-35% of people who are hypertensive, they are on target. And in our country, the figures report that only 3% of the people who are known or diagnosed hypertensive, they are on the targets. So that's a big problem. So we need to have a lot of awareness about hypertension in the masses, because it contributes a lot to human misery. Now, what's the definition? Definition is, the more important word here is the persistent elevation of blood pressure. It's called hypertension because the blood pressure is something which is very dynamic and responds to multiple stimuli. For example, if you are anxious, it's going to go up. So when you have taken alcohol or tea, it might go up transiently. So if it remains persistently elevated, we call it hypertension. If it is only intermittently or spiky, that may be because of the situational circumstances. The blood pressure goes up and then comes to baseline. And this sort of blood pressure generally does not have long-term consequences. But if it is persistently elevated, it is hypertension and produces all those complications. Now, when we say that blood pressure is high, there are multiple classification systems which tell us that this is normal blood pressure, this is high blood pressure. For example, this is JNC 7 criteria, Joint National Committee on Hypertension criteria, which we use as different categories of hypertension. And then you've got American College of Cardiology or American Heart Association criteria that tells that you've got normal blood pressure, elevated blood pressure, and stage 1 blood pressure. So we generally use this JNC 7 criteria. JNC 7 says that any blood pressure which is less than 120 or 80 is normal. So anything above this is abnormal. We call it pre-hypertension if the systolic pressure is between 120 and 139. And the diastolic pressure is between 80 to 89. Stage 1 is 140 to 159, diastolic 90 to 99. Anything above these two readings is stage 2 hypertension, whatever it is. It's more than 160, it may be 200, it may be 300. So it is stage 2 hypertension. We divide this into pre-hypertension, stage 1 hypertension, and stage 2 hypertension. The figures I told you we use for in American College of Cardiology classification, this is elevated blood pressure and stage 1 hypertension. There are only two of these. There's normal blood pressure, elevated blood pressure, and stage 1 blood pressure. But most of the time we use this JNC 7 criteria for labeling patients falling into what category of hypertension they are. Now, there is a primary, or we call it essential or idiopathic hypertension, and then there is a secondary hypertension. Most of the hypertension is essential or primary hypertension. Now, what is primary hypertension? Primary hypertension is when we cannot find an identifiable cause for high blood pressure. There may be causes which can lead to hypertension. That's called secondary hypertension. We'll see what are those causes. So it is essential hypertension when we do not know any cause for the rise in blood pressure. This is most of the time essential hypertension. So you see 90 to 95% of all cases are because of the essential hypertension. The secondary hypertension, if someone under 20 or over the age of 50 suddenly develops hypertension, especially when we suspect a secondary cause, always look for a secondary cause. Now, when do we suspect the patient has secondary cause? Patients with secondary hypertension have got symptoms. Essential hypertension patients do not have symptoms because of hypertension. So it is asymptomatic. Just remember, you will have a lot of people around you, they will tell you that I can know that I have high blood pressure, my head is tightening up, the ears are becoming hot, I know this is blood pressure rising. There is no mechanism in the body which can tell you that you got high blood pressure. Symptoms are only present in secondary hypertension. We will see what are the symptoms. Essential hypertension has virtually no symptoms. It's only when it gets complicated you have got symptoms. So one thing to remember is it is very common disease. Number two, it is asymptomatic. These are the two main problems which we encounter when we start treating these patients. Secondary hypertension, it is 5 to 10% of adults. So in children, secondary hypertension is more common. Primary hypertension in children is less common. So it's the secondary hypertension when a children present with hypertension. This may be because of the coarctation of the aorta. This may be kidney disease. Kidney disease may be parenchymal disease. For example, patient may have glomerulonephritis or may have pyelonephritis or different tubular defects which can present with hypertension, or patient may have vascular defect. That is, there may be stenosis of the renal artery. Then you have endocrine disorders. They may be from the adrenal cortex. For example, patient may have Cushingoid appearance, Cushing syndrome. Patient may have Conn syndrome when there is mineralocorticoid excess. Patient may have because of the adrenal medulla. Adrenal medulla and other sympathetic ganglia can produce catecholamine secreting tumors. So that's called pheochromocytoma. So you may have hypothyroidism, hyperthyroidism, both can have hypertension. Pituitary tumors which produce growth hormone, acromegaly, they can have hypertension. Similarly, ACTH secreting tumors might also have hypertension. Then patients with obesity, sleep apnea, they may have hypertension. So these may be the various causes of secondary hypertension which may be seen in the adults. Coarctation is generally seen in children. In adults, by the time they reach the adulthood, coarctation is generally diagnosed and does not remain undiagnosed. But when you see a child comes with hypertension, look for these causes if any of this is present. In addition to, there are a few other causes of secondary hypertension which I have omitted. They are uncommon. So these are the more common causes of secondary hypertension. Now, the blood pressure depends upon cardiac output and systemic vascular resistance. Anything which can affect the cardiac output or systemic vascular resistance can result in alterations in the blood pressure. Now, how the cardiac output is affected? Cardiac output is affected by the heart rate, the state of contraction of the heart, the neural and endocrine inputs, and then the total volume of the body, which is controlled by the renin, angiotensin, aldosterone system and the atrial natriuretic peptides. So anything which can increase the cardiac output can increase the blood pressure. And anything which can increase the cardiac rate of strength of contraction can increase cardiac output. Now, peripheral vascular resistance is one thing which can increase the blood pressure. I think you would have gone through these subjects in physiology, because I remember they were taught in physiology. That's why I am not going to go into the details of these things. So there are baroreceptors present in the great vessels which respond to blood pressure. When there is increase in the blood pressure, there is a negative reflex which causes decrease in cardiac output. There is decrease in the heart rate and force of contraction, there is vasodilatation of the arterioles. Similarly, if the blood pressure drops, it activates the sympathetic nervous system. There is vasoconstriction, decrease in heart rate and heart contractility, so that adjusts the blood pressure. So this is the normal mechanism which goes on. For example, when you stand up from the sitting position or lying position, the gravity pulls the blood down. The blood pressure might drop because of the decreased venous return. So the baroreceptor come into action. There is peripheral vasoconstriction, there may be some tachycardia, and there is increased force of contraction because of the sympathetic hormones present in the circulation. The blood pressure is immediately restored. So you do not have postural hypotension when these reflexes are working normally. So when a patient presents with hypertension, if you find that the cardiovascular reflexes are maintained, that is, this baroreceptor mechanism is working, the likelihood that this is essential hypertension is very high. In essential hypertension, the cardiovascular reflexes are maintained. They may sometimes be impaired in secondary hypertension. So if a patient on your first encounter you find hypertensive, you check for the postural changes in blood pressure, and if the patient has normal cardiovascular reflexes, the patient has most likely essential hypertension. Peripheral vascular resistance, stress and increased sympathetic nervous system activity increases peripheral vascular resistance, not only through the mediation of the sensory sympathetic nervous system, it also through the increase in the renin release. Renin causes angiotensinogen to be converted into angiotensin 1. Angiotensin 1 is converted in the lungs into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. Vasopressin hormone and angiotensin 2, they are very potent vasoconstrictors. So this produces vasoconstriction as well. So now the second one is the neural mechanism. The other one is the kidney, which becomes important. For the short term, it is the baroreceptor mechanism which adjusts with the blood pressure. And then you got a long term, it is through the kidney. Kidney is the most important organ in the maintenance and elevation of the blood pressure long term. So there is sodium and water retention by the kidney. A high sodium intake may result in water retention. Certain demographics are associated with salt sensitivity, like obesity, increasing age. African Americans, people with diabetes and kidney disease, they tend to retain more of sodium. So in these patients, the possibility of having hypertension is more than their comparators. Altered renin-angiotensin mechanism, there is high plasma renin activity. You see, some of the patients may even have normal plasma renin activity and still they are hypertensive. This is explained on the basis of nephron heterogeneity, that in kidney all nephrons are not alike. Some of the nephrons, they respond differently to different hormones, for example to aldosterone. So they start retaining more sodium. So this, the concept that why patients have a problem because of this is not clearly understood. But it's on the nephron heterogeneity, that all nephrons in one given kidney are not the same. They behave differently, they react differently to the same stimulus. And some of the nephrons, they start retaining more sodium. Endothelial dysfunction is another reason the patient may have hypertension. And now this is the mechanism of how the aldosterone works. This is, the aldosterone causes sodium reabsorption, water reabsorption, increased blood volume and increased cardiac output. So in cardiac output is increased and it remains maintained in these patients. So they go with a high cardiac output state and they develop ultimately hypertension, which is the main reason for developing hypertension. And some of the patients may have insulin resistance and hyperinsulinemia. You see, hyperinsulinemia is coming up as involved in many of the disease processes. The straight one is diabetes, when you've got insulin resistance. When there is insulin resistance in the early part, the insulin rises to control the blood sugar, and then the pancreatic secretion starts falling down, and ultimately the patients start developing diabetes. Similarly, the insulin resistance is involved in the NASH, that is non-alcoholic steatohepatitis, or in polycystic ovary syndrome, or in hypertension as well. So insulin, insulin is what sort of a hormone? It's a catabolic hormone or it's an anabolic hormone? It's an anabolic hormone. So the feature of anabolic hormone is they tend to retain energy and solute substances in the body or into the cells. So insulin also causes sodium retention. So when there is insulin resistance, there is high insulin. That also contributes to sodium retention, and that may result in the generation of hypertension as well. Insulin resistance generally is not present in secondary hypertension. So we see in most cases hypertension results from the interaction of environmental factors, demographic factors and genetic factors. Family history, obesity, ethnicity, sedentary lifestyle, stress, they all contribute to the development of hypertension. And some of these are manageable, some of these are not manageable. Lifestyle may be manageable. Now, what is lifestyle changes? कैसे lifestyle change? What do you call lifestyle change? Lifestyle change ये है कि आपने when you are going to park your car, you're going to park 1 block away, 2 block away, so you walk. Instead of using elevator, you use staircase. Instead of using the remote, you stand up, you change the volume, you come back, you change the channel. So this is lifestyle change. It's not the lifestyle change is meant by that you start living from one environment to another environment. This is when you are living in any environment, you change your lifestyle so that increases and promotes physical activity. Now we're talking of ethnicity cannot be changed, obesity can be handled, family history cannot be changed, stress. Now stress management is very difficult. You know you have to have a lecture at 8 o'clock. If you don't reach there, there might be a problem. And when you're planning to go to the lecture, there are multiple things. You want to sleep, you have to resist sleep. Your breakfast is not ready. You are in anxiety. Amma jaldi tayar karo, I have to go. Problem of transport, traffic. So there are many things which come in your mind. So these stresses are very difficult to eliminate from your circumstances. You have to learn to manage these. And if you are wise enough, you can manage to a great degree these stresses. But you see, for that you have to have understanding that what are the actual stressors and how can they be coped with. So few of these can be addressed, others cannot be. Now there are certain adds on. Systolic blood pressure rises with age. When you have got patients who got hypertension, younger patients tend to have diastolic pressure, which is high. In older patients, it is systolic pressure, which is high. So they tend to have more wide pulse pressure in older age group. The systolic pressure is high, the diastolic is not that high. So they have isolated systolic hypertension, while younger patients have diastolic hypertension. Males tend to have more hypertension even at ages less than 55. Females tend to have higher pressure after the age of 55, after the menopause. Excess alcohol use, smoking, diabetes, dyslipidemia, they all increase the risk of hypertension or developing the complications of hypertension. Now, this clinical manifestation is important. It is referred as silent killer. As I mentioned in the beginning, it does not have any symptoms whatsoever. Hypertension does not produce symptoms. Symptoms are only because when it is complicated. Frequently asymptomatic until target organ disease occurs, and it is sometimes recognized only on routine screening that the patient is hypertensive. Patient is tested for another condition, for example, insurance purposes or for job purposes, or during a routine medical checkup, it's found that the patient is hypertensive, and patient even doesn't know that he is hypertensive. So these are the two different things which you should remember. It's a silent killer, and it's a very common disease. It's asymptomatic. Manifestation may be because when the patient has target organ damage. Target organs, what are the target organs for hypertension? It is the heart and the blood vessels. Okay? It's the heart and the blood vessels. Heart is what? It's a modified blood vessel. So the target organ actually is the blood vessels. So it is heart which is affected, and blood vessels anywhere can be affected. So the manifestation which we see because of hypertension are seen in kidneys, central nervous system, peripheral vascular system, and in the eye. So we call them these target organs in generally, but actually the target organs are the blood vessels, the arterioles which are affected. And these problem in these arterioles produces manifestation in different organ systems. So you may have fatigue, reduced exercise tolerance, dizziness, palpitation, angina, dyspnea. These may be various clinical features which are because of different organ system involvement. Patients may have secondary hypertension, and they may have symptoms because of secondary hypertension. For example, patients with coarctation of aorta, how do they present? They present with weakness and fatigue and claudication in the lower limbs. Sometimes because of the very high blood pressure, they present with epistaxis. And then patients who've got Cushing syndrome, they have clinical Cushingoid appearance. Patient with Conn syndrome, they present with a lot of muscle weakness because there is hypokalemia. Patients who have got pheochromocytoma, they present with spiky blood pressure. When the blood pressure spikes, along with that they have the features of sympathetic overload like apprehension, palpitations and anxiety. So they may have this sort of episodes. So the patients with secondary hypertension presents, depending upon the type of problem they have, they may be symptomatic. Primary hypertensive patients are only symptomatic when they have target organ damage. Clinical manifestation, patient may have manifestations of left heart hypertrophy, patient may have sustained elevation in the apex beat, there may be fourth heart sound. Patient may have features of left ventricular failure, you may see retinopathy in the eye. So it's one place where you can see the vascular and the neural tissue directly. You can watch the blood vessels, you can see the head of the optic nerve. So this is the place in the body where you can see these two tissues directly. So we've got different grades of retinopathy which can tell us about the silver wiring and the copper wiring, AV nicking, the hard exudates. Patient may have sometimes soft exudates, there may be disc edema that's called papilledema. So you may have these manifestations which can be seen on examination. Patient may have features of dyslipidemia like arcus, xanthomas or xanthelisma, they may be visible. You may have features of secondary hypertension, for example, you may hear the renal artery stenosis bruit, or you may pick up the radiofemoral delay. So you may have the features of secondary hypertension which can be picked. Complications, target organ damage occurs in heart, brain, peripheral vascular disease, kidney and eyes. So you can have heart failure, ischemic heart disease, you can have strokes, intracerebral hemorrhage, peripheral arterial diseases which Somer taught you just before my lecture. You may have chronic kidney disease, you may have got problem in the eye, patient may bleed inside the eye. So these are the different complications the patient may have. So this is cardiac complications, and these are the other complications. Now the diagnostic studies, history and physical examination. So history may be unremarkable. What you are going to ask in the history? Patient is asymptomatic, what problem you have? What are you going to ask the patient? About the family history. Family history, smoking, alcohol, the lifestyle, the job. Blood pressure should be measured in both arms. Use arm with higher reading for subsequent measures. So on the first encounter, check the blood pressure in both arms. It should be tested in both arms. The higher side should be taken for subsequent measurements. That is the representative blood pressure, not the lower one. If required, it should be tested in the lower legs as well if you are suspecting coarctation or some other pathology. And first time you should also check the orthostatic, supine blood pressure and vertical blood pressure, they should be tested. Blood pressure is higher in the morning, it's lower when you're sleeping. And one is this white coat hypertension, office BP measurements. You see many patients who come to you, they may have high blood pressure, and when they go back home the blood pressure is normal. This is called white coat or office hypertension. Patients who got office hypertension, they may have normal blood pressure, but these patients, they tend to develop in future persistently elevated blood pressure. So they need to be identified. So you got an instrument which is called ambulatory BP monitoring, which you attach with the patients and continuously record the patient's blood pressure, and then you can decode that reading and find out what has been the blood pressure profile of this patient for that specific period. It is generally 24 hours. So you can have the profile for 24 hours, what's going on. When you check the blood pressure, use auscultatory method with a proper calibrated instrument. Before you do an auscultatory method, go for a palpatory method so you don't have any mistakes in measuring the systolic blood pressure. Patient should be sitting in a chair, feet on the floor, arms supported at the heart level. Appropriate size cuff is necessary because a smaller cuff can give higher blood pressure readings and a larger cuff can give lower blood pressure readings. At least 2 measurements should be taken 1 minute apart. If one arm higher than another, the BP in the higher arm of subsequent, use BP in the higher side for subsequent measurements. This is white coat hypertension, and this is one of you. Non-invasive, fully automated system that can record blood pressure at preset intervals over 24 hours. So this records blood pressure, say if you time it, so it's going to record every hour or every half an hour. So this can sometimes be a problem. If patient is sleeping, the bladder suddenly inflates and it may wake up the patient and the blood pressure may rise out of anxiety. It's also used when drug resistance is suspected, if the patient is hypotensive and patient with drug therapy have episodic hypertension or sympathetic nervous system dysfunction. So this can be used in other conditions as well, but we generally use these patients who got office hypertension and they may require ambulatory BP monitoring. Now, how do you investigate? You go for complete blood count, look for the presence of anemia. Anemia can indicate chronic renal failure, and a high hemoglobin can be associated with hypertension. The polycythemia is associated with hypertension. Go for ESR, inflammatory disorder like vasculitis, glomerulonephritis, they may be associated with hypertension. So go for inflammatory markers. Urine analysis to see for protein, how is the protein, what is the pH of the kidney, urine, and what is the specific gravity. That will give us a lot of information about the state of the kidney. So you go for urine examination. And uncontrolled hypertension, if it remains for a long time, it can lead to sclerosis in the kidney, and that can result in proteinuria. So proteinuria is very important in seeing patients. Serum electrolytes, hypokalemia is important. Patient with hypokalemia may have high mineralocorticoid. So check for the presence of potassium. Hypercalcemia is also associated with hypertension. Go for blood sugar testing. Go for the kidney function tests. Patients with glomerulonephritis, they not only have proteinuria and hematuria, they can also have abnormal kidney function test. So go for testing for the kidney function if there is. You can also go for the ultrasound of the abdomen. Ultrasound can tell us about the size of this kidney, the echogenic appearance of the kidney size. If it is small, it indicates chronic renal failure, and if there is a disparity in the kidney, they've got one large kidney, one small kidney, this may indicate the patient may have renovascular hypertension, the renal artery stenosis may be there. Go for serum lipid profile. Check for the ECG if there is left ventricular hypertrophy. Similarly, you can see on echo the presence of left ventricular function. There is hypertrophy or there is heart failure present. Special tests are done for secondary hypertension. For example, for pheochromocytoma, you have to do serum or urine metanephrine levels. How are they? For this Conn syndrome, you can go for mineralocorticoid levels or the renin activity. So you can do a whole lot of tests depending upon what is the clinical situation.